I'm Dr. Ali, a cardiologist with 3 decades of clinical experience. Today we're going to discuss pulmonary embolism and we're going to decode pretest probability versus clinical gestalt. Um, Physician gestalt is a clinical guess and heavily relies on raw clinical judgment, while pure objective criteria eliminate subjectively entirely and standardized medical inputs. So we compare the Wells criteria versus the um, Geneva criteria. The criteria that are unique to the Wells system include immobilization more than 3 days, that gives you 1.5 points, surgery in the past 4 weeks, that give you 1.5 points. Shared criteria include active cancer, which gives 1 point for the Wells and 2 for the Geneva. Hemoptysis, which gives 1 point for the Wells, 2 for the Geneva. History of DVT or PE gives 1.5 point for the Wells, 3 for the Geneva. Factors unique to Geneva include age more than 65, that gives you a point. Unilateral lower extremity limb pain, that gives you 3 points. And fracture in the past month, that gives you 2 points. So while we use these criteria, we can separate patient risk perception. And as far as the vitals are concerned, the handling of vitals differs significantly. Geneva applies a heavy mathematical gradient to tachycardia, whereas Wells relies on a rigid cutoff. If you consider clinical gestalt alone would single-handedly outweigh red flags like hemoptysis or active malignancy. Therefore, one should be careful about using and relying just on that. Both models stratify patients into low, intermediate, or high probability. Low probability Wells is less than 2 points. Geneva is 0 to 3 points. Intermediate probability Wells 2 to 6 points. Geneva 4 to 10 points. And high probability Wells more than 6 points. Geneva more than 11 points. Now, there's also a simplified scoring that makes it into 2 tiers, and basically PE unlikely or PE likely, and using the modified Wells, P is unlikely if it's less than 4 points, P is likely if it's more than 4 points, and in the Geneva, the cutoff is 2. P is unlikely 0 to 2 points, and P likely for more than 3 points. Now, if you look at the diagnostic yield, patients with low pretest probability actually had 10% PE confirmation, intermediate at 30%, and high pretest probability actually at 65%. So it works pretty good. Now, there's also the PERC rule, pulmonary embolism rule out criteria. Assuming that the clinical gestalt is less than 15%, then any of these factors should be looked into. Age less than 50, heart rate less than 100, O2 sat greater than 95%, absence of unilateral leg swelling, absence of hemoptysis, no recent surgery or trauma in the last 4 weeks, no prior DVT or PE, no oral hormone use. If the risk is less than 15% and all 8 badges are met, PE is essentially excluded. There's no need to test any further. Now, basically what happens downstream from here, patients that are low and intermediate risk undergo D-dimer. If it's positive, CTPE. The high-risk patients go directly to CTPE. Remember, scoring systems are simply vehicles to justify imaging decisions. Now, in the case of pregnant ladies, the risk benefit is different. Therefore, what's called as a years algorithm is used. In this algorithm, if there's clinical signs of DVT or hemoptysis, or if PE is the most likely diagnosis, if any one of these criteria is met and D-dimer is 500, then you proceed with imaging. But in the case of pregnancy, D-dimer is elevated. Therefore, the threshold used is 1000. This prevents over-imaging in populations with elevated D-dimers, such as pregnant patients, and minimizes exposure to X-ray. Now, If we go beyond this and think about prognosis, we can do these clinical criteria: age more than 80, history of cancer, chronic cardiopulmonary disease, heart rate elevated, systolic blood pressure less than 100, O2 sat less than 90. If the score is 0, patient is low risk, 30-day mortality is 1%, consider outpatient management. If the score is greater than 1, high risk, 30-day mortality is almost 11%, requires hospitalization. Therefore, we should take into consideration all of these factors, and the core philosophy using either one of these is to try and figure out which patient is sent to imaging and what the overall patient clinical risk might be. Patients that are low intermediate risk get a D dimer. Patients that are high risk get CTPE. Thank you for watching. More to follow.